Ooh, here comes another big one. Right after pressure sores, what's the other big one? Falls. It's falls. Oh, it's falls. There's lots here, so hopefully I remember it all. Excuse me if I have to look at my paper while we're walking here. It's getting a little warmer, so it's feeling better, but now the trail is getting kind of soggy. So, okay, so let's say you get a call in the evening and they tell you about your loved one having fallen. You know, what do you do? What do you do about that? How do you make sure they're handling it properly? Well, when somebody falls, you know, they should have already done an assessment by the time they call you right off the bat. They should be doing a full body assessment, checking for any kind of injuries or scratches or broken bones or fractures. And if there's any possibility they could have hit their head, they should be checking their neurological signs. This is often called just a neuro assessment in the field. So if I had somebody call me about like my mom or something falling in a nursing home, I'd first want to know some details. I'd want to know where she was at. Like, was she in her bedroom, out in the dining room? What time did this happen? When she was on the ground, was she on her buttocks? Was she laying down, left or right? What were the circumstances around that? And kind of the reason I want to get that is that, you know, if she falls again and then falls again, every time I want to get that, because a lot of times what I found out with nursing homes is sometimes they look at falls in isolation. They'd have a fall every 2 months or something. They'd forget about the last fall, but that there was a pattern to it. You know what I mean? Like they're found wet on the floor outside their bathroom at night. Well, obviously they're going to the bathroom and they need to be toileted before they go to bed, right? But they don't connect the two because, you know, they just look at them separately in isolation. So you want to first make sure you identify any patterns if your loved one is at risk for falling, okay? They should do a fall risk assessment just like they do a pressure sore risk assessment every 3 months and upon admission. So you can have a sense for that, but you probably know that, you know, for your loved one, you know they're at risk for falling or not. Other things to do when you find out that they've had a fall, you want to ask some basic questions. You know, you want to ask, you know, do they have any cuts or bruises or swollen areas? You know, were they able to move their arms and legs without pain? You know, ask that sort of thing just so that, you know, you can get that charge nurse. She's supposed to check all their body and see them. You know, you want to make sure you ask those so that at least she'll be on record and she'll go back and make sure she checks all those things if she hasn't done so. Also, you want to see, you know, did they have any possibility of any kind of head trauma, any injury or any cut on their head, any bruise, or was it, did anybody witness them falling, or could they have fallen and hit their head? Well, if they're somebody like on blood thinners, you definitely want to make sure they're checking their neurological signs. You know, ask her, did she do a neurological assessment? No? Okay, well, could you do it one just to make sure? Oh, they're saying they told you they didn't hit their head? Well, you know, can you trust somebody who might have just hit their head to report to you accurately that they hit their head? No, you can't. So please just do that one neuro assessment, making sure everything's good. Now, you know, that neurological assessment, the reason they do that is because people have what's called brain bleeds. If they hit their head hard enough or if they're on a lot of blood thinners, there's a possibility they could be bleeding in their brain and that could kill them if it goes untreated. So if you do have somebody and your loved one has a cut or bruise on their scalp after a fall, you don't want just one neuro assessment. You probably want one immediately, and then you may want one later in that shift, and you probably want one each day for the next couple days, because a lot of times I've seen them where they'll exhibit the signs of having neurological problems like 2 days later. That's the couple that I've dealt with are always like 2 days later, you know. So follow up with that. If they're on blood thinners, or if you've actually seen there's signs of trauma, or somebody witnessed them and they hit their head, yeah, you probably want to be a little more vigilant about the neurological signs. But, you know, even if they don't have any kind of possibility of that, the next day or two, I would give a quick call and say, hey, how are they doing today? You know, any, are they able to move around fine? Because you want to make sure they're not having any fractures that aren't identified either. You know, are they expressing any pain? Are they any different than they usually are? Just do that as a kind of a little precaution, you know. I would do those things just to make sure. Most times people fall, there's no injury. There's just usually maybe scrapes, bumps here and there, you know. If they're uncomfortable or if in pain, ask them to get some pain medication. That would be appropriate and good. Now, how do you avoid somebody from falling? Now, some of you may say, and this is what the industry was doing for a long time, they would restrain people. Basically, they would either tie them down or they would put barriers in their place that kept them from being able to move. And what we found was that actually caused more problems. See, when I first started doing more work in nursing homes, I remember going into a facility, like when I very first started, you know, right out of college, I spent a little time. God, this is a terrible path. I'm sorry, I'm just dealing with a little, I'm gonna go a little bit off track here. I remember just being almost exhausted at the end of my first day, because you'd see these people like tied down, like their hands and legs were like restrained, and it would be horror. It was a horror show. And I remember, even, you know, 20 years ago, before we prohibited restraints, I'd go into nursing homes and I would see, you know, you'd see these poor people and their heads would be just covered with just a huge bruise. That's called ecchymosis, where the blood just pours in because they'd fallen. You see like 2 or 3 people like this. And then you'd see like 1 or 2 that you knew, my God, they are just gonna break their hip anytime now because they're so at risk of falling. And, you know, maybe it's anecdotal or coincidental, or maybe it's just me, but I don't think it's just me, because I think studies have shown this, that, you know, that once we've gotten them off those restraints, that has gone away, that's not totally gone away. Yeah, you still have people at risk of falls. That's, believe me, that's not going away, but that restraining them made it a lot worse, and it made it a lot more risky for people. Even if they're confused, you know, psychologically, can you imagine being tied down and not knowing why you're tied down and then trying to get up and you're strapped down? Can you imagine emotionally how much that harm that caused? Plus, when you do maybe get out, you don't have the leg strength and you immediately just drop like a sack. I think somehow, even if people are confused, somehow they inherently know that, or somehow the body adjusts to that. Big plus is that, you know, these restraints, people would often get, you know, they wiggle their way into getting strangulated. How can I say that nicely? Even bed rails, which, you know, people probably think, oh, bed rails, they're not going to hurt. They're not going to be a problem. No. A lot of people get entrapped and die in bed rails, and it's ugly. So I am like, good riddance, glad we're not using it anymore. So I'm saying all of this because you might think, oh, we need to do this and that will keep her from falling. But no, you don't need to do that. That's just gonna hurt her more, okay? So enough said about restraints. I think you get my point. Okay, so what can you do if your loved one is at risk? Sorry, this trail's kind of crappy. You know, I think more than anything, just, you know, like I was kind of emphasizing early on at one point, you know, coordination and leg strength. If you can get, you know, supposedly you can get maybe an order from a doctor to get restorative nurse aides to do a little program, and that's fine, that's something, but a lot of times they're not consistent with it. You know, if you have the resources at all, I would find out if there's like a physical therapy aide that goes there. If they're really at a fall risk and they're falling, you might be able to get a doctor under Part B Medicare to order some physical therapy. That's one, okay? But if you can't get that, you might just be willing to pay a little bit of money to get a PT aide to do 2 or 3 times a week maybe just 15 minutes of exercise to get them more strong in the legs and stable. You know, as long as they're not too terribly confused and you follow simple directions, that would be a help. Okay, you can't afford that. Well, can that physical therapist spend, 10 minutes with you explaining some exercise that maybe you can do with your loved one, right? Because you can go in there maybe 2 or 3 times a week and do these exercises, and then you won't have to pay that. The important thing is to try to get, if you're going to pay anything, try to get the therapy aid, not the therapist. She's going to be way more expensive, okay? But I think that's the primary thing you can do that's going to help your loved one prevent them from falling more than anything else. Other things you can do, if they're confused, you know what? There are roommates that aren't confused, and, you can establish a rapport with a roommate, and I bet that roommate will kind of keep an eye on your loved one a little bit. And when they see them doing things that are unsafe, you can ask them to call staff or ask them to help out. And don't make it like an obligation, but just mention it casually somehow. And people, the way people generally are, they want that sense of purpose and meaning. And if they know they have to look out for your loved one and they like you and they like them, they're going to do it. If they're human, they'll do it. The other thing is sometimes too, think about the location of where the charge nurse station is, kind of where they centralize that. Well, the closer the room is to that nurse station, the more frequently nurse aides walk by those rooms that are closer, because when they're going down to different rooms, well, if it's the room closest to the nurse station, you're always going to the station, that's what you're going to go by. So it helps to have your loved one close to the nurse station because you got more eyes looking in every time they go by. They look in. Are they on the floor? Are they doing something unsafe? They see that, right? So that's a good one. Posting reminders. Remember how I said, you kind of have to remind Steph for this or that and the other thing? Same thing here. You might want to put reminders up, but this time you want to put reminders up for your loved one because they may not remember, hey, I should use the call light instead of, getting up on my own if I need to use the bathroom or something like that. So if they're able to have enough awareness to look at reminders that are posted near their room for them, you might want to consider doing that. That's one possibility. And then I don't know if I already mentioned it or not, but if you do have somebody that frequently falls, I would meet with the DON, at least at the care plan, or if it's really serious, they keep falling like really frequently, have more than 2 or 3 in 1 month, I'd probably get a meeting right away. Just the fact that you have a meeting probably means that they're going to make sure that they got a good care plan intervention in place or get one in place for them. Staff are generally pretty busy and they zip through these care plans rather quickly when they review them. You want to make sure enough time and attention is given to your loved one's risk of falling and that some good interventions are put in place. And then you want to be the one to say, okay, thank you for that. And when you go in, you just check, okay, and if you can physically check to make sure that intervention's in place, all the better. That's one other thing I would recommend doing. Okay, well, I hope those suggestions might have helped you. Will help protect your loved one. I'm going to talk a lot of just a kind of a random number of care issues to kind of be aware of on my next video. If you found that video helpful, please give me a thumbs up. Go ahead and share it with friends. And if you want to get more information, go ahead and look into www.nursinghomerisk.com. That's nursinghomerisk.com. And I will see you at the next video.